growth charts and growth monitoring. In this webinar, we shall learn about the need for growth monitoring of preterm babies, growth parameters to be measured, which growth charts to be used, how to plot growth charts, identification of growth impairment and its management. Premature infants have greater nutritional needs to achieve optimal growth. However, due to inherent limitations, many very low birth weight babies will have cumulative deficits in protein and energy, resulting in slower growth than their intrauterine counterparts, thereby causing EUGR or extrauterine growth retardation. Hence, provision of adequate nutrition from birth along with growth monitoring is essential to prevent this. The ideal growth targets for preterm babies based on intrauterine growth rates are a weight of 15 to 18 grams per kilogram per day, a length of 0.9 to 1 centimeter per week, a head circumference increase of 0.7 to 0.9 centimeters per week. What are the objectives of growth monitoring? To ensure that postnatal growth is optimal and that the baby is growing along the birth centile, postnatal growth parameters of these babies should be diligently monitored using growth charts. This will help in early identification of growth faltering so that nutritional and other interventions like management of cold stress, sepsis, anemia, etc. may be carried out for improving the growth trajectory, and the response to our interventions can also be assessed. For monitoring growth, the three parameters that are routinely tracked are weight, length and head circumference. The standard practice should be to weigh the VLBW infant daily until discharge, then twice a week or weekly until term, and then monthly until 12 months of chronological age. Babies who are unwell are weighed more frequently. The length and the head circumference should be recorded once weekly until term and monthly thereafter. We shall now learn how these anthropometric measures are taken in separate videos for this purpose. Two types of growth charts are commonly used for monitoring preterm babies' growth. Firstly, the intrauterine growth charts that are generated from the anthropometric data at birth from preterm babies delivered at various gestational ages. Examples of this type of charts are the Fenton's charts and the intergrowth 21st charts. The other type of growth charts are the postnatal growth charts based on longitudinal postnatal weight of preterm babies. The Ehrenkrantz charts are an example of postnatal growth charts. Most neonatal units plot early growth on the Fenton intrauterine growth charts. These charts are also called standard or prescriptive charts. There are separate charts for boys and girls for all the three parameters of weight, length and head circumference on the same chart. The same charts are used at birth to characterize babies as appropriate, large or small for gestational age. Now, as these charts are based on the intrauterine growth standards, they do not take into account the normal postnatal weight loss that occurs in babies in the early days after birth. Weights that are plotted on these charts are equivalent to the WHO growth charts at term gestation. So, no change in the centile occurs when transitioning from the Fenton to the WHO charts at term. Many centers use the Ehrenkrantz charts, which are postnatal growth charts, to assess the adequacy of postnatal growth. These longitudinal curves represent postnatal growth and portray how the baby is growing after birth. These charts allow for the initial postnatal weight loss seen in newborn infants. They are also therefore known as reference or descriptive curves. Let us look at how to plot the growth chart by taking a couple of examples. Baby A. This baby was born at 30 weeks of gestational age with a birth weight of 1100 grams. The postnatal course of this baby was uneventful. There was no RDS. Enteral feeds of mother's milk was started on day 2 and was scaled up to full enteral feeds by day 7. The baby's weight was 980 grams on day 7. The weight of this baby was continued to be plotted and the baby regained the birth weight on day 15. Thereafter, there was a steady weight gain, and as you can see, at 28 days, the baby is following the appropriate curve. Now, baby B. This baby was born at 30 weeks with a birth weight of 1250 grams. The baby had RDS requiring CPAP for 72 hours. The baby had been started on minimal enteral feeds on day 2, with gradually daily increasing in the volume. However, the baby had repeated episodes of feed intolerance in the first 2 weeks of life, requiring IV fluids. As you can see, there was a significant loss of weight to 930 grams on day 14. The baby regained birth weight only by day 25 of life, and at day 30 was still below the birth curve, though the weight gain improved after initiation of KMC and fortification of mother's milk from day 21 of life. If poor growth or growth faltering is identified, then the likely cause needs to be identified and addressed appropriately. Let's take a look at some of the common reasons for poor postnatal weight gain and their management. The commonest reason for poor postnatal growth in the convalescent period is inadequate protein and caloric intake, which needs to be addressed by optimizing feed volumes to say about 160 to 180 ml per kilogram per day of expressed breast milk, as well as perhaps by fortifying the milk to provide 120 kilocalories per kg per day and 3.5 to 4 grams per kg per day of protein intake. Occult cold stress may also impair growth, and maximizing KMC duration per day may help better growth. Other problems like anemia, prematurity, hyponatremia and occult infections like urinary tract infections, fungal sepsis may also cause growth faltering and need to be investigated and treated appropriately. Once a baby has reached the corrected age of term, further growth monitoring should be done on the universally used WHO growth charts. So, at the end of this webinar, I wish to highlight that VLBW babies and ELBW babies are prone to extrauterine growth restriction. Growth monitoring of weight, length and head circumference is essential for all preterm babies. Monitor on the Fenton's, that is the prescriptive charts for classification of nutritive status at birth, and the Ehrenkrantz charts, which are the descriptive charts after birth for postnatal longitudinal growth. Use growth charts to monitor faltering and to monitor effectiveness of corrective interventions. Fortification of mother's milk and KMC would help improve the growth velocity. Thank you.